Irvine. Dr. Torphy is actively involved in research in the field of headache medicine. We have a lot of doctors in our community, but not that many that are involved in research, so I think this will be a new, fresh perspective for everyone. He's presented his research findings at numerous national and international conferences. He holds a dual bachelorette in biology and history from Indiana University. Prior to attending medical school, he held numerous positions at the Johnson & Johnson Corporation as well. He received his Doctorate of Medicine from Xavier University School of Medicine, where he was awarded the President's Scholarship. He also completed his residency at the University of Illinois College of Medicine, affiliated with St. Joseph Hospital in Chicago, Illinois, where he served as chief resident. Currently, he's the managing director for the Chicago Headache Center and Research Institute, where he serves many patients, but also as one of my greatest mentors.
Oh, thank you. Thanks a lot. I appreciate it. Yeah, thank you. And does this work also? This is just for the recording?
No,
this is
just for
Okay, so maybe I can hold this too. Okay, perfect. Well, thank you so much. I mean, I really appreciate the opportunity to be here. And, you know, I actually come from the school of, if I'm not 15 minutes early, I'm 15 minutes late. So I really apologize for cutting it so close, and the traffic was a little tricky getting out of the city. But I really appreciate so many people coming this morning, because I know certainly during Ramadan, headaches can increase, but I also thought this would be an opportunity to talk about headaches in general. Just a few slides. Don't worry, I won't bore you too much about migraine and other headaches, but I really, really appreciate the interest. I would argue that probably everyone here either has someone in their family who experiences migraine, or they know someone who has migraine. So hopefully everyone will leave here with a good bit of information, not just about headaches around Ramadan, but also migraine and other headaches. So I know to get started, we want to do a survey. And this is really the brainchild of Aman. And I want to take this opportunity to thank Aman, but then also just to give you a little bit of our perspective of Aman. Aman mentioned that I'm his one of his mentors, and what a privilege for me. But I have to tell you, you know, Aman must be someone that all of you are extremely proud of, because when he started working with our practice, now about 3 months ago, I mean, from the very first time we met him, he brought a light to our practice, a light of positivity, a light of empathy. And really, I would tell you that having Aman in our midst has made all of us, including me, all of us better prepared to care for our patients, not just with the knowledge that we have, but just with that empathy and enthusiasm. So I know he's someone that you're all very proud of, and you absolutely should be. And I'm proud to have him in our midst. So this is a survey. So if you don't mind, if you have a cell phone, and I'm a little technologically challenged, so Aman might have to help with this, but if you open up your camera and zoom in on the QR code, it'll take you to a survey. And I think there are maybe 10 questions, Aman. How many questions are on the survey?
It's also sent in the WhatsApp group, if you guys have access to that.
Oh, perfect. So it's in the WhatsApp group as well. And this will be really helpful if you'll do this, because one of the things that you know, Aman is so talented with his pre-med studies and soon-to-be med studies, but also with research. Because one of the things I've tried to instill in everybody that I work with is everything that we do, there's an opportunity to research it. So this particular survey, what the goal is that you'll take this survey, you know, before this Ramadan, and then you'll take it again after Ramadan. And I think Aman will facilitate that. And then the goal will be to see, do people have improvement during Ramadan regarding their headaches after having attended this program? So we certainly hope so. That's our goal, is to help. So we can always pull this back up a little bit later if for some reason you're not able to pull it onto your phone. So the agenda today, I always think it's nice to have a little bit of a roadmap. So we'll talk a little bit about various types of headaches. We'll talk about migraine. We'll talk about tension headache. There are numerous headaches, but those are the most common two. And then we'll talk about what's been deemed the Ramadan headache. And I was curious, having this on the screen, is this the first time that anyone's heard this headache referred to as the Ramadan headache, or is that something that you've heard before? You've heard it before?
I experienced it.
You experienced it, okay. So you could actually, share with us probably your experience. You'll see a little later, but I think it's about 40% of people do experience a Ramadan headache of some kind. So we'll talk about that. There's actually even some research that's been done I was able to find, and so that's quite interesting. And then maybe most importantly, we'll review ways to prevent the headache. So the best treatment of headache, and certainly the Ramadan headache, the best treatment is really prevention, because it can be rather difficult to treat, certainly during the fasting time. And then we will talk about some treatments, but that's going to be a little bit limited during the fasting hours. So prevention really is the key. And so what are the types of headaches? So the most common primary headaches, when we talk about headaches, we really talk about primary headaches and secondary headaches. So primary headaches, those are headaches that are due to a neurological condition within the brain. And then secondary headaches are caused by something else. So when people come into our practice, the most common thing that we see at the Chicago Headache Center is migraine. It's the most common reason a person would talk to a healthcare provider about their headache. Tension headache is actually more common than migraine, but most people wouldn't actually talk to their doctor about tension headache. Most people at some time in their lives have experienced a tension headache, but most of the time they wouldn't talk to their doctor about a tension headache. So migraine and tension type headaches. Examples of secondary headaches would be if somebody has caffeine withdrawal, which is one of the issues that sometimes we see during Ramadan, right? Caffeine withdrawal, a sinus infection. If somebody has a sinus infection, that could cause a headache. Interestingly enough, though, one of the most common misdiagnoses that we see in our practice is someone who actually has migraine, and they've thought for years that they get sinus headaches. Sinus headaches often occur around weather changes. Actually, migraine often occurs during weather changes as well. So one of the most common sources of referrals to our practice is actually ear, nose, and throat doctors. When patients have gone to an ENT doctor thinking they have sinus infections, and they get a scope or a CT scan of their sinuses, and they realize that they're clear, and it actually is that they have migraine. Certainly, a brain tumor could cause a headache as well, a secondary headache. And of course, that's what we all fear when we're having a headache is there a brain tumor? But that unfortunately would be a cause of a secondary headache. So we have primary headaches and secondary headaches. So we'll just have a slide or two about migraine. It's, again, the most common reason a person would come to our practice. So migraine is a complex neurological condition. It's not just a headache. In fact, one of the challenges when people have migraine is if someone says to them, oh, it's just a headache, you'll be fine. Actually, there are a lot of symptoms of migraine, and headache is usually present, but it's actually not always present. So it's usually a symptom, but not always. So if we think of migraine as a condition that has attacks, so a lot of times a person will say, oh, I'm getting a migraine. Well, what they really mean is they're getting a migraine attack. So people have the condition of migraine that ends up having attacks here and there. And normally, the pain is of moderate to severe intensity. So this is the kind of headache where people miss work, they miss school, they miss family functions, because it's a moderate to severe headache. It's oftentimes one-sided. Not always, though. Plenty of my patients with migraine have headaches on both sides of their head. But generally, it's one-sided. And a lot of times a person who's experienced a migraine attack, they'll say it's throbbing or pounding. The pain is pulsatile or pounding. So really, really problematic. Oftentimes people with migraine will have nausea. Most people with migraine actually don't vomit. That's a misconception. A lot of even doctors think, well, if the person doesn't vomit, it's not migraine. The reality is most people with migraine don't vomit, but most of them do have some degree of nausea. Sensitivity to light. These lights are helpful so that we can see each other, but these overhead lights in our office, we try to turn them down because, of course, everybody coming into our practice more or less has some kind of headache. So these kinds of lights can trigger a person to get an episode of migraine, but if they're in the midst of a migraine attack, overhead lights, fluorescent lights, can actually make it worse. Sensitivity to sound. So a person who has migraine, if they're having an attack of migraine, they may say to their family member, "Oh, you're speaking so loudly," when in fact, maybe we're not, but they're extra sensitive to the sound. I didn't put it on there, but sensitivity to smells. Sensitivity to smells is a big problem for people who have migraine. Oftentimes, if a person is around someone wearing strong cologne or perfume, if that person gets migraine episodes, that can actually cause an attack of migraine. I didn't realize that until I started working with folks with migraine several years ago, but that's something that we can all be mindful of that if we're wearing perfumes that are too strong, that can trigger people to get migraine attacks. In our practice, our employees aren't even allowed to wear any kind of cologne or perfume because it can be problematic for our patients. So there's something called an aura. Most people have probably heard of aura. An aura is seen only in about 20 to 30% of people with migraine. So most people with migraine don't get an aura. But an example of an aura would be, if you think of your visual field, if you think to the sides, you might get some zigzag lines or dark spots. Sometimes it even takes over the whole visual field where a person with migraine can't see. And usually that happens about 20 to 30 minutes before a migraine episode, before the pain occurs. Could last up to an hour, and that's oftentimes followed by a headache. But again, most people with migraine don't get an aura. So usually, when I talk to folks about what's the difference between migraine and tension type headache, in most cases, if a person gets a migraine episode, it can get worse just with routine activity, just by climbing stairs, walking around the block, going about your day. Whereas a tension headache oftentimes will actually get better if a person gets distracted, starts to do some exercise, goes for a walk. A tension headache might actually improve, whereas a migraine episode would usually get worse. Migraine is 3 times more common in adult women than men. So if you look at our practice, most of our patients, if they're adults, most of them are women. You know, maybe if we see 20 patients in a day, we might see, 5 to 7 that are men, but most of them are female. And we think that estrogen probably plays a role in that, but even people that have already had menopause, usually migraine episodes go away, but not always. So what are some migraine triggers? So I mentioned that migraine is a condition that is characterized by attacks. Well, what can bring on attacks? And I think if we look at these, we can think about, even during Ramadan, some of these could become triggers for us, right? Missing meals, well, that plays a role. Stress, weather changes, menstrual period for females. Generally, it's a day or so before. There's a drop in estrogen, and that can trigger a migraine episode. Missing sleep, so if someone's sleep pattern has changed. So a couple of these things are really characteristic of what we experienced during Ramadan. And then dehydration. So it's almost as if I could superimpose the word Ramadan over migraine for some of those triggers. And that's why Aman thought it would be a good idea to talk today, and I'm so glad that he did. So let's pivot over to tension headache. And there's a reason why I wanted to go through migraine and tension headache, because the Ramadan headache is really characteristic of both. Please, yes?
Will you be sharing this presentation?
I certainly can, yeah. In fact, at the end, there's a page with references, and I would encourage you to even visit those pages. A couple of them are web pages, and so you get those tips. But certainly, I'm happy to share these. Yeah, of course. So tension headache. Tension type headache, as I mentioned, is more common than migraine. I think almost everybody in any room would at some point in their lives have experienced a tension type headache. It's the most common headache. It's usually mild to moderate. So most people would not miss work or miss school for a tension headache, unless they had a big exam the next day and they didn't want to go take the exam. But usually it's mild to moderate intensity. It's oftentimes bilateral, we say, or both sides. But not always. There are always going to be exceptions to any rule in medicine, and certainly in headache. Usually it's on both sides. Usually it feels like a squeezing or just a pressure. It's usually not throbbing. There's less disability, like I mentioned. And we don't tend to think of nausea being correlated to tension headache. It's not to say that it can't, but that's usually not something we tend to see. And as I mentioned earlier, sometimes if a person has a tension headache, it can actually get better if they have physical activity. So going for a walk, going to the gym can sometimes help a tension type headache. Most people with migraine would never go to the gym if they're having an episode. So what are some triggers for tension type headache? Well, stress, whether it's physical stress, whether it's emotional stress, whether it's mental stress, while that can trigger migraine episodes, it can also trigger tension type headache episodes. And if you think about it, if someone's stressed out about something, they might kind of tense their muscles, they might bite a little bit, they might hold on to things tightly, and that can cause muscle tension in the head, in the neck, and in the shoulders. A lot of our patients will tell me, oh, I tend to carry my tension in my shoulders. And when we do certain treatments, one of the treatments we do is Botox, and when we inject certain places toward the shoulder, you could even tell that there's a lot of tension there, and a person would carry their tension. So that can lead to tension headaches. Poor posture. So if you can imagine, if a person's at the computer, like this lady is at the computer, if she's sitting kind of to the side there like that for a long time, that can cause tension, that can cause strain in the muscles in the neck and the shoulders. You know, all these muscles are connected, so it can all lead to a headache. And then eye strain. So there she is looking at the computer. So if she's looking at the computer for many hours on end, that can strain those eye muscles. Since the change that we've seen with COVID, where so many people are working remotely, so many people, instead of having in-person meetings like this, so happy we could be in person, but having a Zoom meeting and just always being at the computer, we've seen a rather large increase in people who have eye strain that can trigger migraine and also tension type headache. So let's move to the Ramadan headache, and really it's as if we were kind of setting the stage with the migraine and the tension type headache, because there can be features of both with the Ramadan headache. So it's been estimated that about 40% of people who are fasting could experience a Ramadan headache. If you're comfortable sharing, would we get a raise of hands of people who have had a headache during Ramadan? So the vast majority of people here, so even over 40%. Now from a research standpoint, if I asked Aman, why is it over 40%? He would probably say we have a skewed sample, because people who have experienced headache would be more likely to come to a session about headaches. And I'm thrilled that you all did. So those with a previous headache history are more likely to get headaches during Ramadan. So if a person has maybe a genetic predisposition to getting migraine, that person may be more likely to get a Ramadan headache. The phenotype, that's a big word, right? But the way that it's expressed, the way that the condition is expressed in a person who has migraine, the phenotype of their Ramadan headache may be more like migraine. If a person has tension headaches, well, during Ramadan, their headaches may be more tension type headache. So this is more common in females, which is exactly what we said earlier about migraine. 3 to 1 more common in females. So the Ramadan headache is more likely to happen in females, but plenty of males will also get a Ramadan headache. The pain is usually bilateral, or both sides. Now, I said earlier that people with migraine usually have one-sided headaches, but I also said people with migraine plenty of times will get both-side headaches. So the same is true with Ramadan headache, but it does tend to be more bilateral, or both sides. So that's a little more like a tension headache. It can have a throbbing quality, which is more like migraine, but it can also have a non-throbbing or a pressure feeling, which we would think of more like a tension headache. Another big medical word, the frontotemporal is where it's usually located. That just means forehead and sides, where the temples are. So this is usually where that headache is, frontotemporal. So the frontal area, which just means forehead, and then the temples. And it's generally a mild to moderate severity, but certainly different conditions. What I like to share with my patients, and it's not on any of the slides here, but even when we think about migraine triggers or headache triggers, if we think about Ramadan headache triggers, sometimes there can be a stacking of triggers. So let's say that a person is fasting and it happens to be a day when there's a weather change. Well, if the weather change usually triggers a headache or a migraine for that person, even outside of Ramadan, If we add fasting to that, that could stack 2 triggers on top of each other. And then if the person happens to be under a great deal of emotional stress, well, that could be another trigger. So what I try to encourage my patients to do is let's try to control what triggers we may, knowing that there are going to be some triggers that we can't control. So if a person is under a particular amount of stress, well, let's try to reduce that stress as much as possible. And of course, during Ramadan, the reflection and the meditation and the prayers and all hopefully can help to alleviate some of that natural stress that a person would have. Often the Ramadan headache may last 1 to 2 hours. Migraine, by definition, an attack of migraine should last over 4 hours. So again, this would be a feature that makes it seem a little more like a tension headache. So 1 to 2 hours is usually what is experienced, but certainly there will be exceptions. So how do we prevent the Ramadan headache? Again, we said earlier that the best treatment of a Ramadan headache is a good prevention, and that's true of a lot of headaches, but hydration. And I can imagine this is not news to anyone. Probably you already have your own strategies, but hopefully this will help to kind of augment those. So it's recommended to drink at least 2 glasses of water with your iftar. So at least 2 glasses of water with iftar. And then try to drink between 8 to 10 glasses of water from iftar to suhoor. Now that can be challenging because you're also going to see that in a couple of slides I talk about try to get good sleep. Well, if you're drinking a glass of water every hour, that can be a challenge. So ultimately, at the end of the day here, you'll want to develop a strategy that works for you, but here are certainly some guidelines. It's recommended to get those 8 to 10 glasses of water to pace yourself by having at least 1 glass of water every hour. Again, when I read that and I think about trying to get some several hours of sleep in a row, drinking a glass of water every hour can be challenging. So we have to find a balance there. But importantly, if we avoid salty processed foods, that can help us. Because if we eat too much of the salty processed foods, that can cause water retention, which can then lead to this dehydration-induced headache or migraine. So not too many salty or processed foods. Now sleep, getting to sleep. Of course, this again is a balancing act between getting the water and also the sleep. So it's recommended to adapt the sleep schedule to try to get 7 to 8 hours of uninterrupted sleep per night, which again can be challenging if we're trying to drink a lot of water. Good quality sleep is more likely if we have light meals for iftar and suhoor. And so that can also be challenging because I can imagine after fasting, your person's ready to eat a big meal, but keeping in mind that ultimately you're going to want to get good sleep. And try to allow enough time for the food to digest before going to bed. That also can be a challenge, but can be very, very important. Try to choose a quiet, dark place for 4 to 5 hours of sleep before waking up for the suhoor. After suhoor, try to sleep another 2 hours before waking up for your day. And obviously, everybody's schedule is going to be different. Maybe a person has to, get on the road to get to work. But these are guidelines. And again, at the end of the presentation, you'll see the few reference sites that I visited, and hopefully you can visit those as well. And you can try to adapt this to your particular needs. If possible, try to take a 20 to 40 minute power nap at noon to try to revive your energy and keep going after iftar. So that's not going to be possible for everybody, I know, but if there's a way that a person could take a power nap, that can also help. One of the things I try to tell my folks at the office, patients, is that the migraine brain likes for things to be consistent. So anything a person can do to instill consistency in their day and in their life can make it less likely they'll get as many episodes of migraine. So regular meals, regular sleep, regular stress, and anything that upsets that apple cart, if you will, upsets that consistency, can trigger the brain to release certain substances that can lead to headache and migraine. So really making sure that we really get as much water as we can, that's important, and regular meals as much as possible. And certainly during Ramadan, that's where we have the challenge that we want to put together a strategy. So caffeine. Aman was so nice to bring a cup of coffee up here because he knows I like coffee. So I think for me, this would be a particular challenge were I fasting for Ramadan. So I really, really wanted to be attuned to this. Without exception, the best way to prevent a caffeine withdrawal headache during Ramadan is to cut back from caffeine a few weeks before Ramadan. And Aman was so astute to ask me to come to give the presentation today, because now we have, a bit of time, right? Almost a month, maybe not quite a month until Ramadan starts. So assuming you're not someone that drinks 10 cups of coffee a day, we have time to cut this down so that there hopefully won't be such an impact of caffeine withdrawal. So it's recommended to reduce caffeine by about 25% per week. So if you're someone who drinks 4 cups of coffee a day, every week try to cut down by 1 cup of coffee a day, so that when we enter Ramadan, you're not expecting, your body is not expecting you to consume as much or maybe any caffeine. What would not be a good idea would be to continue to have those 3 to 4 cups a day up until just before Ramadan and then stopping. As a side note, how much caffeine in coffee is too much? Well, I suppose that's going to be individualized, but as a general rule, if someone experiences migraine, it's recommended not to have more than 1 to 2 cups of coffee a day, or the equivalent. So anything above 1 to 2 cups a day, if someone comes to my office and says they're having a lot of headaches or migraine episodes, one of the first things I will do is say, well, let's try to cut the coffee down to 1 to 2 per day. So think about reducing by about 25% weekly. Now, if you do plan to drink coffee during Ramadan, here are some, in my opinion, important points to keep in mind and a strategy. So it's recommended to have 1 cup of coffee as soon as possible after your iftar. And then after that, try to get in a quick workout, because that workout will hopefully burn that caffeine, so that the energy from the caffeine, so that you can get a restful sleep after Isha. So when I looked at that, I was thinking, okay, that's probably the opposite of what I would do. I probably would say, after Supor, I would probably want to have my coffee, because I would say, I need to get my day going. But the reality is that could set a person up to get a caffeine withdrawal headache throughout the day before iftar, which is interesting because the study that I reviewed in putting this presentation together, that was actually when the majority of people who had a headache history, most of them experienced a Ramadan headache a few hours before iftar. And that was considered based on hypoglycemia or low blood sugar, and also caffeine withdrawal. So according to these recommendations, it would be best to have your cup of coffee, if you're going to have coffee, as soon as possible after iftar, and then a workout to try to burn that energy so you can then sleep. And then if you are going to drink that caffeine or coffee during Ramadan, it's recommended to have more water, because caffeine can be dehydrating. So keep that in mind as well. So I mentioned hypoglycemia, which most of us have probably heard that term, but it's low blood sugar. And that can trigger certain people to get headaches. People who frequently get headaches are more prone to getting headaches because of the hypoglycemia, as I said, particularly just before iftar. So it's recommended to limit your intake of sugar the week before and during the month of Ramadan. It's almost as if I'm bringing bad news, right? We have to cut down caffeine, we have to cut down sugar, but hopefully there will be a return on investment. It's recommended to avoid sugary drinks, because if you have a sugary drink, then you can have a sugar crash shortly thereafter. I mentioned earlier that the migraine brain likes for things to be consistent. Well, the same would be true for all of our brains. We don't want any big drop. And so a big drop in the sugar can then lead to a sugar crash, which could cause a headache. So what should be eaten? Again, a lot of these things, I bet a lot of these things are things that your parents probably told you in preparing for Ramadan. So hopefully there's some consistency here. But to eat filling, slow-release energy foods that are high in protein. So examples would be meat and fish, nuts, beans, eggs, And what do we try to avoid? Well, it's recommended to avoid processed foods or foods that are high in sugar. What kind of carbohydrates? Well, it's recommended to have whole grain carbohydrates. So examples would be brown rice and oats or a wholemeal bread. So not a lot of complex carbohydrates. So what if we do get a headache during Ramadan? What kind of treatments are available? Well, essential oils. We really focus in and hone in on home remedies during the fasting hours. So essential oils. So examples of essential oils could be eucalyptus, peppermint, rosemary, lavender, chamomile. And it would be recommended to have, kind of a diluted essential oil, and you can rub those gently, massage them into the temples. I suppose if a person's having pain in the forehead, you could also gently rub on the forehead, but usually it's the temples. And if the scents, the smells might be bothersome for some people, so I think you want to plan ahead and strategize which essential oil does not bother you. And if all of the essential oils tend to bother you, you could also use a cool compress or a warm compress. Some people prefer cool, some people prefer warm. It depends on kind of what works for you. A cold compress on the head or on the nape of the neck, that can actually be helpful. It's not recommended to do that more than about 15 minutes though, because that could then end up triggering headaches or causing other issues. Some people prefer to have a warm compress. Some people prefer a cold compress. Really, it depends on your individual style. Meditation, the relaxing and deep breathing. As I said, that kind of pairs nicely, I would think, with the prayers that are incorporated anyway. So hopefully a person could incorporate the meditation to help alleviate some of these headaches. So what about after breaking the fast? What options are available? Now, certainly it's important to talk to your doctor or your healthcare provider before you take any medicine, even if it's over-the-counter medicine, if you have any kind of healthcare condition or medical condition. But generally, after you break the fast, over-the-counter pain relievers like acetaminophen, Tylenol, ibuprofen, Advil, Aleve, naproxen. Again, talk to your doctor before you use those if you have any medical condition, but usually those are helpful. Oftentimes, having the iftar, eating, will then alleviate the headache if it's a hypoglycemia headache. Electrolyte replacement drinks, those have become more popular recently. Those, for some people, could be helpful as well. So there are some strategies. But you'll see, in terms of treatment, there's really only one slide because there really aren't too many treatment options. So the best treatment is going to be a prevention. And so that concludes the slide presentation. This is Cusco. So this is our Director of Recreation and Happiness at our office. And so I know Aman is always very good with Cusco when he comes to the office. But I always incorporate him into my talks because he usually tends to put a smile on people's face. But I wanted to take the opportunity to invite anyone to ask any questions that you might have. This is a real honor for me to be here today. Please.
Caffeine decaffeinated. Will that allow people to drink more than 1 or 2 cups? And secondly, common headache and classical headache. Because classical headache is less common and common headache is more. In common headache, do you get all the other features except the aura?
Yeah. Oh, thank you. Yeah, very good. You must have a medical background to know about classic headache and common headache. So, good question. So the first question, if I understood correctly, is what about decaffeinated tea? And yes, or even coffee. The reality is decaffeinated coffee still has a little caffeine in it, but a much smaller amount. So yes, a person, in my opinion, would be able to have more cups because there's a very, very small caffeine content. So yeah, that would be another strategy. But I think if a person drinks regular coffee, a couple of cups a day, thinking about it today, I would not recommend that person just move over to total decaf today, but maybe gradually, over the course of the next few weeks to prepare for Ramadan. The other question was common headache versus classic headache, and that's why I knew he has a medical background, because we think about migraine with aura. So migraine with aura, I mentioned earlier that only about 20 to 30% of people who get migraine have a visual disturbance, what we call an aura. And that typically used to be called classic migraine. Yeah, now we call it migraine with aura. And common headache or common migraine, just like you said, not only do you have a background in medicine, but you're very sharp with your background in medicine, because common headache or common migraine is more common than classic. Yeah, most people that get headaches or migraine will not experience an aura. Yeah, very good. Thank you for the questions. Please. Oh, okay.
Migraine headache, does it have anything to do with your age? So as you grow older, the episodes are less frequent, or any time will not happen again? Is there any age where it will just stop and you won't have any migraine attacks again?
Good question. So the question is there any age when is there any age when a person may stop having migraine? And the answer is usually yes. But then I'll put the asterisk on there that there are always exceptions. But the majority of people who have migraine, usually in the case of a female, because we mentioned that migraine is 3 to 1, 3 times more common in females than males, usually people who are going to start to get migraine, if they're female, they'll start around menarche, so in their teenage years, in their early teenage years. And then they'll go through periods of time in their lives when they have more episodes of migraine, and then periods of time when they have fewer episodes of migraine. And then usually, not always, but usually after menopause. So after menopause is completed, in most people, migraine goes away. But even in my office, I mean, we don't see too many people in their 70s or 80s, but I do have some patients that are in their 80s who still get migraine episodes. They're considered VIPs in our office because we don't see them very often, so we treat them extra special. But most of the time after menopause, they go away. But if they aren't going away, they could continue onward for several years, but in an up and down cycle. Sometimes more episodes and sometimes fewer episodes. Yeah. But if anybody is having migraine and having headaches, it's really important to have some kind of treatment strategy, because it can really be disabling to worry about the headaches and worry about the next time you're going to get them. And the reality is, in the last 5 years, there have been new treatments that are available. So I would encourage you, I mean, I would love for you to come see me, but to see anybody, you know, a doctor, a healthcare provider, because they can help you. Yeah. Thank you.
What triggers you to do further workup if there's any pathological underlying cause?
A good question. So the question is, what triggers us to do a further workup if we think there may be underlying causes? We said earlier about secondary headaches, so a headache caused by something. So the most important thing that we consider in our practice is the history. So the headache history. If a person if this is the first headache of their lives, if this is the worst headache of their lives, in those cases, if it's the worst headache of a person's life, we recommend they go to the emergency room, because they need quick intervention and quick assessment with a CAT scan to make sure they're not having a stroke or a bleed inside the brain. But if someone has a long-standing history of headaches, if this is something that's been going on for years, then it's less likely to be caused by something else. If there's a family history, we know if one parent has migraine, each child has more than a 60% chance of having migraine. If both parents have migraine, it's over 80% likely that each child would have migraine. So if there's a family history, if a person is having headaches that have had the same features for many years, usually we consider those comfort signs. But what are some red flags? Red flags, which is really what you're asking, to make us think that we need to do a CAT scan or we need to, send them to the ER. If the person all of a sudden begins waking up with headaches, If usually they would get headaches in the afternoon or evening, and I don't just mean, for a few days or a month, like during Ramadan, but let's say for 2-3 months the person is now waking up with headaches. That makes us a little more concerned, and so we would send that person for imaging to make sure there's not a brain tumor, quite honestly. If whenever we do a neurologic exam, if we notice that there are certain, they're called deficits. So let's say if I ask a person to move their eyes and they're not tracking the way they're supposed to track, or if when I ask them to squeeze my hand, if there's weakness on one side, if I look at the way they walk down the hall when they're going to schedule their follow-up visit, if they're a little bit wobbly, if the person says that they're all of a sudden clumsy and they didn't used to be clumsy, if there's a history of trauma. So there are things that we look for, but usually when people come to our office, oftentimes they've already been assessed by their primary doctor and they've already had the imaging, but it's always something we have to keep in mind. Yeah, thank you. Any other? Oh, please, yes. Yeah, I may give you the microphone. No, don't worry.
Yeah, my first question is about the Botox. You had mentioned how it was being used for tension headaches and the neck. Can you just speak more about that? And then the other question I have is kind of like a trivia question because, I get the aura but no headache, thanks God. But I get it when I look at maybe light, like a flash of light off the water will give me an aura, but no headache. Is it still called a migraine?
Yeah, thank you. Yeah, thanks for those questions. So first of all, with respect to the Botox, so Botox, the way it works, if we think of Botox, most people think of people getting Botox for wrinkles, but how that occurs and how it works is that it relaxes the muscle. So if you think of a person with wrinkles, if the muscles are relaxed, the wrinkle kind of goes away. And so in migraine, in fact, the way Botox is approved by the FDA, it's actually for migraine, not for tension headache. But one of the ways Botox works is by relieving the tension. So where we inject Botox for migraine, and that's actually all we do it just for migraine, but there are injections in the forehead, the sides of the head, the back of the head, and then here in the trapezius muscle. So if you think about it, where a person has a lot of tension, when the Botox relieves that tension, really paralyzes the muscle, it reduces that tension. It's also thought that Botox has another mechanism of action where it works kind of deep in the brain to inhibit the release of a certain substance that you probably don't want to necessarily know about or hear about, but there are a couple of ways that we think Botox works. So that's kind of the strategy with Botox, is that it does release some of that tension and then has a secondary mechanism of action. So right now, if someone has more days of the month with a headache than without, if that person has migraine, the diagnosis is chronic migraine, and most of us think Botox is the single best treatment for the prevention of chronic migraine. And then your other question about having the aura without pain. So some people would call that an ocular migraine. Most of us in the headache world would still call that migraine with aura, because there doesn't always have to be pain associated with it. So to your point, you're fortunate, it sounded like you feel you're fortunate because you're not getting pain, which I would agree with that. But oftentimes the aura can be disabling as well if you're not able to see. So we would still consider that a migraine episode, migraine with aura. And depending on the number of times that a person may have that during the month, a person might benefit from prevention medicine to make it less likely that as many episodes would occur. Right now, the sort of powers that be would say if a person gets a couple of episodes a month and they're not having any disability associated with it, they probably don't need to be on a prevention medicine. But if that happens 6-8 times a month, most of us would say, we probably would try a prevention medicine to see if we could keep them away. Yeah, great questions. Thank you. Yes, please.
Is there a relation between migraine and a stroke? The person who gets migraine may end up having a stroke too. Is there a relation there?
Good question. So it's clear that a lot of you have what we would call good healthcare literacy. So you know a lot about headache, about medicine. So yes, we know that people who get migraine Again, remember, most people with migraine don't get an aura, they don't get the visual disturbance, but even those people do have a slightly increased risk of stroke over the general population. It's not a huge increase, but it is an increased risk. If a person has migraine with aura, so with the visual disturbance or the numbness and tingling, it's a heightened risk, so it's an even greater risk of stroke. So we do see it. So what does that mean practically? Well, some people, some providers recommend if a person gets migraine with aura that they take an aspirin a day. Most of us don't say that unless there are other risk factors. But for example, if a person were to take estrogen, so let's say a female after menopause, we're going to take estrogen for postmenopausal symptoms, or a birth control pill with estrogen. If they have aura, it's recommended that they don't have any estrogen supplementation because that is also a risk of stroke, having estrogen, extra estrogen. Smoking, so a person with migraine or migraine with aura certainly should not smoke because that's another risk of stroke. So we try to reduce the risks that the person would have. Yeah, so really good question. I know that you had a question right there. Do you still have a question? Yeah.
My way of dealing with migraines or headaches during Ramadan is I take a slow-release caffeine pill right before Fajr. Is that recommended?
Oh, okay.
Is that okay? And it's been working fine for me, but I'm not sure if there's any side effects.
Did I hear you take it just before the iftar? You take it?
No, before Fajr, in the morning.
Sorry. Okay. I'm sorry. Yes, take it in the morning. So you mentioned the slow release caffeine pill, and only during Ramadan.
Yeah.
Yeah.
Otherwise, I drink coffee.
Yeah, I think that sounds, to me, that sounds fine. Yeah, the one thing that other people in the headache world might say, well, we don't want you to do that because it could lead to a caffeine withdrawal headache and more headaches, but that would probably be if you did it all year round. We're talking about a finite amount of time, so having a caffeine pill. I'm always thinking about research. Every step I take, I'm always thinking about research, and now I'm thinking, Aman, maybe we should study that. We should have people take caffeine, a slow-release caffeine pill. I think it sounds reasonable. You ask if there are risks. I mean, certainly, I would argue no more than the coffee that you're having. You could get, increased heart rate and all, but the coffee could do the same. Thanks.
Yeah, I was just wondering, what are your treatment options for tension headaches? Definitely not migraines, because I know I don't have the aura, but I do get the tension headaches.
Yeah. Well, one thing I will say, most people with migraine don't get an aura. 80% of people with migraine don't get an aura. So just because there's no aura, I wouldn't say that would mean that it's no migraine. But to answer your question specifically, what do I treat for tension headache? Normally an NSAID, a non-steroidal anti-inflammatory drug like ibuprofen or naproxen. Those are generally what we try. Sometimes muscle relaxants. So if a person has a lot of tension, what we sometimes find in our practice is if we give the person a muscle relaxant at bedtime for a few weeks, oftentimes that will reduce the tension to the point where they don't have to take it all the time. It's very tough to take a muscle relaxant during the day because it can make a person drowsy, but we find if we just give it at bedtime, oftentimes the person can take it for a short amount of time. But yeah, I won't argue with you if it's migraine or tension headache, but just because there's no aura doesn't mean that it's not migraine. Yeah.
How would you know the difference? Would it be light sensitivity?
Generally light sensitivity, sound sensitivity. So you might not. You're probably right. Yeah. About once a week I see someone that truly has a tension headache, and you might be that person. Yep. Please.
I don't know whether you covered this already, but one of the major problems with young people is during sports injuries. They have concussions with football and even with baseball, with basketball. I know of numerous instances where they either hide from their parents the fact that they have symptoms. How do you recognize a concussion based on headaches? Is that a common feature?
Yeah, good question, because a lot of student athletes, if they know they're going to be taken off the field, they may hide the symptoms, the headache. So, I mean, generally, by the time a person comes to our practice, certainly if they have had a head injury and they have not had imaging, we usually would get imaging. But a concussion is often a clinical diagnosis. So if the person's having some brain fog, having difficulty concentrating, and a lot of that's based on history. So that's incumbent on the patient or the student athlete to be honest about what's happening, because there's really not imaging that we would take to say, okay, well, this person has a concussion. The imaging is just to make sure that there's nothing else going on, like a bleed or that kind of injury. Usually it's based on history. If they're just having trouble concentrating, dizziness, there could be some clumsiness as well. You didn't ask this, but what's usually the treatment? The treatment for a concussion is usually resting the brain. So a student that's in a high-level math class, we might say, okay, for a couple of weeks, don't do any math because you need to rest your brain. That's usually the easy part. The hard part is telling them they can't look at their phone for those couple of weeks. Yeah, good question. Please. Oh, great. Oh, okay, yeah, since I'm here, and then there's one over there. Yeah, thanks. Oh, okay, does it work? Yeah.
So I have two questions.
Okay.
Does chronic migraine cause dementia? That's one.
Okay.
The second one is, with preventive medication and chronic migraines lasting 7 days or more, how do you cope with those kind of migraines?
Great question. Good question. So the first question is, does migraine cause dementia or lead to dementia? But I will tell you that's an area that a lot of people are interested in these days, but there's not any good data, to my knowledge, that shows that correlation. I think it's something that needs to be studied further. So no, I don't know that there's a cause that's been shown, but certainly plenty of patients with migraine will have dementia, but not a cause there. But certainly people are looking into that. What about if someone has 7 days of a migraine episode? Because usually a migraine, by definition, an episode of migraine is at least 4 hours. By definition, anything between 4 to 72 hours. So 4 hours to 3 days. Anything after 3 days, it's oftentimes seen that the typical medicine that a person may use to treat that migraine episode, after 3 days, it's less likely to work. It actually gets a new diagnosis at 3 days. After 72 hours, a migraine attack or episode is called status migraine. If someone has an asthma attack that doesn't go away, it's called status asthmaticus. If someone has epilepsy and they have a seizure that's not going away, it's called status epilepticus. So with migraine, we stole that name and said it's called status migrainosus. And so usually the first thing I think of is a steroid. So a steroid is a good anti-inflammatory. We don't like to use steroids too often because there can be side effects, difficulty sleeping, that kind of stuff, and bone thinning if they're used long term. But most providers would think of a steroid. And I would say in the vast majority of cases, a 5-day course of a steroid usually gets that person out of that migraine attack. Yeah. Yeah, great question. I know you had one more, and then
Very quick one.
yes.
Is there any place of sedatives and tranquilizers for tension type headache?
Good question. So I would tell you that there are a few patients that I have that if stress is a major trigger for their tension type headache, that occasionally I will have a sedative for that person. But in my practice and in my experience, if that person is not also under the care of a psychiatrist or a psychologist, I strongly recommend that that person become part of our healthcare team, just because I don't like to prescribe a lot of sedatives and those type medicines. So it's usually a small amount. But the question was, is there a role? And I think in some patients there could be a role. Yeah, definitely.
Thank you. So,
oh, okay. I'll talk to you afterward. Yeah. Thanks.
We may have to close here. I want to sincerely thank you.
Thank you.
Really a pleasure to have you here, and thank you so much for the great talk.
Yeah, thank you. Thanks.
And we get the one for some snacks in the back. Just quickly, if you could go back to the research.
Yeah,
let's.
oh, that's perfect. Yeah.
So currently we only have 15 responses, and we have way more than 15 people here.
Oh, yeah.
It's really important that everyone fills this out, because when I was doing my literature review for this, there's only been about like 3 studies on this, and none of them have been in the US. So think of this as you're participating in some cutting edge research, because part of the reason why I want to do this is to promote health literacy in our communities. And unfortunately, in our clinical trials, we have like 8 active studies, but I don't think there's a single Muslim patient.
Right.
So because of that, I think this is a good way to get started. It's only 10 questions. It takes 2 minutes. There's nothing invasive. So please fill this out. We also sent it on WhatsApp. So that'll be great. But
Can I
again,
say one thing?
yeah, of course.
I was just going to ask if I could say one thing along those lines. So, I mean, as I said earlier, and there are people that weren't here when I mentioned this, but how proud you must be of Aman. I mean, we're so happy to have him in our midst. But participating in this survey will actually directly help Aman, because what he plans to do is he'll look at this survey, and then after Ramadan, those who completed the survey will also get the survey again, and he's going to analyze whether or not there was improvement. And he doesn't need this help because he's already been admitted to at least one medical school, and I would say whichever medical school is fortunate enough for him to choose them will be all the much better. But this would be another feather in his cap to be able to publish something that shows some improvement. Hope I'm not skewing the data by saying that, but it really would help him to participate. So thank you in advance. Yeah.